Good evening to all who are present here. Thank you for joining this evening for the SAFE session, which is conducted by the ANEI Patient Safety Fellows. Let me share the screen. Yeah, it's a monthly program, which is the Safety Awareness for Excellence program, purely conducted by the ANEI Patient Safety Fellows. So before we begin our session for today, let's join together for the ANEI anthem, after which we will start our session.
We are the voice, the hands that care, guardians of hope, always there. With wisdom and courage, we stand tall, answering the call, serving all. In every moment, through joy and strife, we lead with purpose, we honor life, building the future with knowledge and grace, transforming healthcare in every space. Passion to action, our guiding light. For every life, we fight the fight, upholding safety with hearts so true. We are ANEI, proud in all we do. Together we rise, united we lead, planting the seeds for a brighter tomorrow. Together we rise, united we lead, planting the seeds for a brighter tomorrow. ANEI, nurses make the difference to humanity, shaping the future with strength and unity. Passion to action, our guiding light. For every life, we fight the fight, upholding safety with hearts so true. We are ANEI, proud in all we do. We are ANEI, proud in all we do.
So once again, welcome. Kindly inform your other colleagues, friends, and students to join the SAFE session brought to you by ANEI Patient Safety Fellows. As you are all aware, the ANEI Patient Safety Fellowship Program is a 2-year program, which is by the Patient Safety Movement Foundation, USA. The culture of safety The session is purely taken by the ANEI Patient Safety Fellows. And every year, it's a 2-year program, and fellows join and they do a study at their own areas. And this 2026, we have decided for 12 topics, which covers the patient safety culture. And June month, we are here to present to you. Diksha will be presenting. So before that, I would like to announce about the annual Patient Safety Conference, which is held at Hyderabad on the 18th September. Save your dates. We will be informing shortly about the conference and also about the competitions which will be held at your own places. So save the dates as 18th September at KIMS Hospital, Hyderabad. So this particular conference is purely conducted by the ANEI Patient Safety Fellows. As I already told you, it's a 2-year program, and those who have completed takes up the responsibilities to conduct the same. So these are the 12 topics which is lined, and now we are in the month of June. So presenting you Diksha Patil, who has completed her MSc Nursing from Neurosciences. She's a tutor at College of Nursing, AIMS, Nagpur. She is cohort 5 from 2025 to 27 batch. And her mentors, she has 2 mentors. One is Tangraj, who is from AIMS, Nagpur also. He's also an MSc nurse and a quality coordinator at AIMS, Nagpur. He is 2024 to 26 cohort 4 batch. And along with him is Dr. Elizabeth Workey, who is cohort 3, which recently got graduated during the ANECon. She's 23 to 25 batch. So why am I saying about the cohort is the 5th batch in progress, and very shortly we will be taking up cohort 6. So those who have joined, you can share the information to others. We will be sharing the flyer about the selection process. So today we have Diksha, who will be presenting on the science of near miss learning without blame. And next month, we have Sagarika, who will be presenting on medication safety in emergency and critical care. So happy learning to each one of you. You can share your information or any type of doubts. You can share it in the chat box. At the end of the session, we will be clarifying your doubts. Over to Diksha.
Thank you, ma'am. Good evening to all. So myself, Tangraj, it's my privilege to moderate this session and the science of near miss learning without blame. So, when we talk about the patient safety, often we will must to think about what are the adverse event and what is error that was happened and how much the patient was harmed. And we thought that so much of learning will be embedded in that studying the adverse events. But nearly the learning we will get when the patient was not harmed and it was just missed by missed, and if someone is identify it in the right time, so the harm should not be occurred. So this incident is called as near miss, and it have more valuable insights, so which tell us what are the weakness in the system, which is to be identified and which is to be corrected, so that the cost of that error should not be bear by the patient. So every adverse event, when we thought out adverse event, so this all adverse event have any some small near miss events which was not like identified, which was not identified with someone, and finally which was led to the adverse event. So why that near miss is important? Because when we talk about the patient safety, so this is a patient safety is a global burden and challenges for the healthcare provider. So how to maintain? So in this, near miss plays a very important role, because that hampered in the patient safety, that was lead to the not only affect the patient and family, but also affect the trust in the healthcare system and negative impact on the healthcare providers. So to make further to understand the importance of near miss, I invite all of you to watch one small video that was a small video. that was made by Patient Safety Movement Foundation.
I'll never forget the day that my 4-year-old son Logan almost died in my arms in Royal University Hospital. We were sitting on his hospital bed when he let out a scream. And I knew that he shouldn't be screaming because he shouldn't have been in any pain. A bag of potassium that was a concentrated, heavy concentration bag was hung instead of a diluted bag. As a pharmacist, I know that when the concentration of potassium is too high, that it can burn. So I knew when I looked behind me and saw potassium hanging that the concentration Logan had been given was too high for him, and as a result could have killed him. I immediately locked his IV and I started to cry and shake with all the chaos going on around us. I went over to the bedside, saw that she clearly was upset about something. And he looked right at me and he said, "I have no idea what you're talking about, but I trust you and I know that you know there's something wrong. I'm here to help. Let's figure this out." We rolled Logan down to the OR waiting room where we met up with the anesthetist. And come to find out, he didn't even know that Logan had a kidney condition. He wouldn't have required us to increase the potassium if he had known that in advance. I firmly believe that everybody that day was working with my son's best intentions. I work in the system myself, and I saw errors. I've been involved in errors before, but the way Saskatoon Health Region handled this error has been incredible to watch. Their openness to understand that there are safety defects in the system and their openness to work with me and to try to fix them have been unlike anything I've experienced in my own healthcare career to this point. The most important thing that I learned from this whole experience was that, first of all, we as healthcare providers need to talk to each other. We need to be able to listen to the families. If we are in a situation where we're not sure what's going on and we're not comfortable with the situation, we can't be scared to just push the stop button and figure out together what's really gone wrong. Safer Every Day is a 90-day initiative.
So, okay. So now we have saw on video. So now I request everyone take one pause and think, and reflect what we have watched. So suppose someone like, what if no one has like spoken up? What if like no one has like finally cross-checked that error before occurring? And so what if error has reached to the patient? So unfortunately, the consequence of error was maybe life-threatening and like maybe losing of the life of one baby. So there is a near miss. So which was rightly identified and rightly it was escalate. So this near miss plays valuable roles in and tell the important learning opportunities we have. In our day-to-day life situation, often we come across the many near which we have prevented the patient harm. Like we have done prevented the wrong medication administration by cross-checking, and we have prevented the wrong procedure by correct identification. Sometimes we are not able to report that, and we not think so. It is very important. So it is very important to report near miss because it provides the insight what is the problem that was existing in system and how to be corrected, and so and ultimately it prevent any incident to be happen. So with this thought, now I like to request Ms. Diksha, patient safety fellow, cohort 5. So take a session and take a safe session. So and make us to like better to understand what is near miss, what are the importance of near miss, and how to report the near miss, and what are the things that has to be done, like how to create the just culture, everything which will further strengthening the near miss. Okay, thank you. Over to Ms. Diksha.
Good evening. Good evening, everyone. I would like to thank Tangaraj sir for the introduction. My sincere gratitude to Tangam ma'am for giving me this opportunity to be a part of ANEI Patient Safety Fellowship. I also like to thank Roslyn ma'am for her guidance and support. My special thanks to my mentors, Dr. Elizabeth ma'am and Mr. Tangaraj sir, for their continuous support in preparing the safe session. Please allow me a moment to share my screen. Could you please confirm whether my screen is visible and my voice is audible?
Yes,
Yes,
even
Diksha. Diksha, you can proceed.
Just a second, ma'am. I'm unable to see. Okay. Now it is visible, ma'am.
Yes, it's visible.
So today I'm pleased to present my topic, the science of misses learning without blame. So before we begin, I would uh, like to, ma'am, is it sound is coming double?
No,
Hello?
it's okay.
Okay. Sorry, ma'am. So before we begin, I would like to call all of you. You think about your last duty shift. You were administrating medication. Maybe you were checking patient identification. Maybe you were handling blood transfusion out of this. Now let me ask you a simple question. How have you ever caught an error just before it reached to the patient? If you please drop into the chat box. Maybe you have noticed a wrong dose. Maybe you have found a wrong patient label. Maybe you have detected a documentation mistake. If yes, then congratulations. Many healthcare workers think safety is only about the preventing adverse event. But if you found this early, it means you have already contributed to the patient safety. However, some of our greatest learning opportunity come from the incident where harm did not occur, and these incidents are called near misses. And today's session is about understanding why they are so important. So, the learning objectives of today's session is define near miss and patient safety incidents, why reporting near misses is important, and the science behind near misses, the difference between blame culture and the just culture, identify the barriers to reporting near misses, strategy to improve reporting of near misses, and the role of nurses in creating a safer healthcare system. So, let us have a look at the global patient safety burden according to the Patient Safety Fact Sheet 2023. Patient safety remains a major global challenge worldwide. 1 in a 10 patient experiencing a harm during healthcare delivery. Additionally, more than 3 million deaths each year are associated with the unsafe care. The encouraging fact is that more than 50% of patient harm is preventable through the safe, timely, and evidence based care. Despite advance in healthcare, patient harm continues to be the one of the leading cause of the death and disability worldwide. Unsafe care not only affect the patient and their families, but also increase the healthcare cost, reduce the trust in the healthcare system, negatively impacts workforce well-being, and hinders the progress to avoid the universal health coverage. So, to understand why near misses are important, we first need to understand the anatomy of error. Not all the errors are the same. The point at which an error is detected and determines both its impact on the patients and learning opportunity for the healthcare system. First one, intercepted error or near miss. This occurs when an error is identified and corrected before it reaches to the patient. For example, I will like to give the examples of it. So wrong medication is prepared, but it's caught during the double checking process. Since no harms occur, and this provides a valuable learning opportunity. And second, no harm incidents. So, no harm in this situation. The error reaches the patient, but fortunately does not cause any harm. Example, a duplicate medication dose is administered, but the patient experienced no adverse effect, although no harm occurred, and this should not be considered a success. Instead of, it is the warning sign because the next patient may not be so fortunate. Third one, adverse event. This occurs when the error reaches to the patient and can cause harm, injury, disability, or even death. For example, a potassium overdose leading to cardiac arrest. This is the most common example which we know about the adverse event. So while learning still occurs, it comes at very high cost because the patient has already suffered harm. The earlier we detect an error, the safer our patient remain. Near misses provide us with the greatest opportunity to learn and improve without patient harm. So, what is near misses? As we have already discussed, a near miss is an incident that did not reach the patient and it had been potential to cause harm but was intercepted before it occurred or before it happened. According to WHO, the definition of near misses is an event that could have resulted in the harm to a patient but did not either by chance or because it was intercepted before reaching to the patient. Now we have discussed this. Why we have to study near misses? Why it is important to study about the near misses? Let me explain with a very simple example. Imagine you smell a smoke coming from a room, and will you wait for entire building to catch fire before taking the action? Of course not, because you will immediately investigate the source of the smoke and take corrective action before the disaster occurs. So near miss are like the smoke. They are the warning signals. They tell us what almost went wrong and needs early intervention, where the system is vulnerable and require improvement, and how future harm can be prevented by providing critical information for learning and systemic redesign. Just the smoke help us to prevent a fire. Same like as near misses help us to prevent a patient harm before it occurs. So that is why near misses are so valuable. They give us the opportunity to learn, to improve, and to strengthen the patient safety without patient we get injured. Now let's discuss Henry's triangle. Now, for according to this triangle, for every one serious harm event, there are 30 minor harm events and 300 near misses. Near misses are the foundation of the pyramid. They are early warnings that the system has weakness. Iceberg theory. Think about iceberg theory. The serious adverse event is only on the tip. Underneath are the numerous near misses. So if we focus only the serious events, we miss the valuable learning opportunities. So if we focus only main things, so we have to we have to more focus on the near misses. So in other words, it's called near misses is equals to free lesson and the adverse events is a expensive lesson. So up to now we have discussed near misses, why it is important and how it is benefits were to know earlier. So have you ever wondered why serious adverse event occur even though we have policies, trainings, protocol and experienced staff? Because every safety barrier has a weakness or holes. And this is what this James Reason Swiss cheese model explain. What does each slide of cheese represent? You can see here, there are the slides of cheese. And here it is given one circle. So this is the we can consider as a whole. Okay. So what does each slides of cheese is represent? Each slice of cheese is a safety barrier or defense layer in the healthcare. And the barriers are, what are the barriers? Education, training, policies, technology, communication, and then checklist. All these barriers are designed to prevent the patient harm. What do the holes represent? These are holes are there. What it exactly represent? So it represent the weakness and the failure. Examples are human factors, which is like such as fatigue, stress, distraction, communication gaps, handoffs or unclear orders, and the system failures, workload, equipment, and the policy gaps. The key concept of this model is a single hole usually does not cause harm. Patient harms occur when there is a hole in the education, hole in the training, hole in communication, and the hole in the checklist. So all holes are aligned and then error reaches the patient. So we can link to the near miss. Suppose a nurse detect the error at any stage. So error can be stopped there and there itself. And this can create a near miss. So therefore, every near miss represent a successful safety barrier. The most important message for nursing officers are nurses are often the final barrier, final we can consider final checker and the final defender of the patient safety. This is why nurses identify wrong medication, wrong dose, wrong patient, and the wrong blood products. That's why nurses is also called as the last line of the defense because she can find out medication discrepancy such as wrong dose, patient identification, wrong patient flag, allergy alerts, contraindicated of regarding any drugs which can be stopped immediately, or the blood transfusion mismatches, incorrect unit identified earlier, and the procedure error. We can see the wrong site or the wrong step caught during the procedure and the documentation inconsistency, discrepancy in the corrected. So nurse save a patient every day by identifying the near misses. Now, importance of reporting. As we know, near misses, we know that it is the event which is we are finding out before getting harm. But why it is not that coming up? Only because lack of reporting. So near miss is important, but more is this that it should be get reported by the staff nurses or the healthcare members. Unfortunately, many near misses remains unreported. And why? The most important, identify the system flaws. So this can be there is a fear of punishment, heavy workload, lack of time, and then lack of feedback. So some staff thinks that nothing happened, so why I need to be report? But no, this thinking can be the dangerous. So we should have to be report. If it is reporting, then it will gives you the identify the system flaws, proactive preventions of the particular harm. So we can find out the solution as early as. If you have not reported and it can what the cost of silence can occur. So fear because of the fear of blame, punishment, time consistent, lack of feedback, and belief in the personal responsibility. This be the mainly reason of unreported near misses. But what is the cost of silence? This can cause the system weakness, remain hidden. The same error will repeat with the patient, and future patient harm occurs that can lead to the disability or death also, and organizational learning stop. So every unreported near miss is missed opportunity to protect the patient. Now, how we can strengthen this near miss reporting, the key initiative from blame culture to the just culture. Now only I have told you why it is underreported because of this. So, because blame culture is there. So we have to be strengthen this from blame culture to a just culture. Imagine A nursing officer makes a medication error. So in the blame culture, first question will be, who made this mistake? But in just a culture, the first question is, why did mistake occur? Was the medication label confusing? Was staffing inadequate? Was communication unclear? A just a culture focuses on the learning rather than the punishment. So a just culture approach, it is a culture, it is a culture creates a foundation of a trust by differentiating between the human error and the intentional misconduct, fostering an environment where the staff is encouraged to report incident for a system improvement without fear and unjust blame. It helps to balance the accountability. It shifts the focus from who made it mistake to why did mistake happens. It encouraged the transparency and it build the confidence in the staff. So it increase the trust in reporting the systems. This is the just culture framework. Here we have to be understand there are human errors. If human errors is there, so the accidental slips or the mistake happen. So respond is there, console and we can support. In the just culture, at risk behavior, choosing to deviate from procedure, believing it's justified or efficient, then we can coach and re-educate. But the reckless behavior, such as consciously disregard of substantial and unjustifiable risks, then response should be appropriate accountability. So, not all the errors deserve punishment. Most errors reflect system vulnerabilities and not individual malice. What is the cost of punitive culture? So, a fear reattribution leads to the concealment. What will happen? Because of punishment culture, all the nurses, officer, healthcare team will try to hide the near misses and silently the earning warnings that prevent catastrophe when the staff fear punishment and they stay quiet and the patient pay the price. The study shows that punitive culture reduces the near misses reporting by 60 to 70%, delaying critical safety improvement. WHO emphasizes that fear-based system hide the early warnings and that prevent the catastrophes. Now we will discuss about the HROs, that is the high reliability organization. What is high reliability organization? It is the organization that works in the high risk environment but consistently maintain the high levels of safety. The most common example is that aviation and the healthcare system, leading healthcare system. So they focus on the basically 5 principles to understand learning from the small errors and near misses. So understanding the complexity of the system. Second principle, staying aware of day-to-day operation. Third, adapting effectively during the unexpected situation and respecting the expertise of the frontline staff. So the important message for us from the HROs, do not wait for the patient to get harmed or to harm occur. They learn from the near misses and use them as an opportunity to improve the patient safety. That is why near misses reporting is a hallmark of high reliability organization. Now, what are the strategies to promote the near miss reporting? Like how we can promote the near miss? As we have discussed, we have the what are the it should be feasible, easily available. So what happen? It will help the nursing officer, healthcare team to get easily reported. So first of all, anonymous option. It should provide a confidential channel to report without fear. Simplified forms, which is streamline the reporting process to reduce the burden. It should be very simplified. What are, like we can make it Google form and it should be confidential in the simplified form. And mobile reporting. It is very enable and quick accessible reporting from any location. Timely feedback. Demonstrate the reports are reviewed and acted upon promptly. Then leadership support. It is most important that leadership Leaders should be support visible commitment from the management to just a culture. And in recognition programs, reward and acknowledge proactive safety contribution. And safety hurdles. Safety hurdles integrate the brief, regular discussion about the risk and then near misses into the daily routine. Now, the nursing specific strategies, that is the safety hurdles. Daily leaders can ask, any near miss happened today? Is any medication concern do you have? Any patient identification risk is there? Or any staffing issues? So this is very small hurdle can help the small consistent discussion are critical for preventing major incidents and fostering a culture of continuous improvement. Now, what are the role of leaderships? So, first upon, it should be encourage the open communication. There should be a open communication, foster an environment where the staff feels safe to speak up without fear. Second, avoid public blame. Address error constructively and privately. Focus on the system improvement. Conduct learning focus reviews. Investigate the near misses to understand what is the main root cause, not just the assigned fault. Next, share, listen, learn. What exactly near miss happened and how it got, what was the root. So after finding this, it is most important to share it. Then only it will be more useful. So disseminate the insight from near misses across the organization to prevent the reoccurrence. And the celebrated the good catches. That is the recognize and praise individual who identified the prevent potential harm. So this is regarding the good catch program. A good catch occurs when someone identifies and prevent the potential harm. For example, a nurse detects the wrong insulin dose before administration. So the patient remains safe. And this nurse deserved recognition before because harm was prevented. So we should celebrate the vigilance, not only the outcomes. So it will encourage to nursing officers. Now, the near miss learning cycle, how it should be. First of all, most important, that is the timely reporting. First, as it should be report on the time as it occurred. So documenting identified near misses through the established secure channels. Then need to be find out the root cause analysis. What is the reason behind it, how it happened, what is the main weakness. After that, disseminate the learning and sharing insight and lesson learned across the organization to prevent the recurrence. Then system improvement. It should be improvement into the system such as procedures, policies, and then equipment and safer patient care, achieving a continuously safer and more reliable environment for all the patient. So this is the near miss learning cycle. So learning without blame. Embarrassing a culture where the mistakes are seen as an opportunity for a growth, not a punishment. So transparency block, blame culture, what blame culture will? Blame culture stifle open communication, prevent honest reporting and systemic learning. And learning centering approach, shift focus from the individual fault to understand the systemic issue and proactive prevention. Higher reporting rates, psychologically safety encourage reporting, yielding critical care data for continuous improvement and strengthen the awareness. Ongoing education empowers staff to identify the risk and foster a safe patient environment. So these are some research finding which I have I'm presenting here. The author Buder et al. Given in 2024 that near misses have the same contributory factors as an adverse event. See, It is as equally contributing as like adverse event, such as human factors, communication failure, system issue, but remains significantly underreported. So key message of that research is that every near miss is an early warning signal of future harm. Second research finding is that given by Alphys on the done the systemic review, the major barriers to reporting were the fear of blame, lack of feedback, and the poor safety culture. This inadequate knowledge and limited leadership support. So it is most important that just a culture and a leadership support improve near miss reporting. It is the most important thing. Then Isabara author given in the study they have done in 2025, they have done a survey on the 51 nursing leaders. Out of 96% encountered medication error, 37% perceive underreporting, and barriers including lack of knowledge, extra documentation, 47%, and fear of blame, 45%. So the key message of this research finding is that fear and the blame significantly reduce the reporting. So there should be a blame-free culture is very essential for the good reporting. Then author Baby done research in 2026. Approximately 5.2 million medication errors occur annually in India. Reporting remains low due to the fear of punishment and the lack of awareness. So you can understand what is the importance of reporting over here about the near miss. So near miss reporting is critically to prevent patient harm and they improve the medication safety. So key take home message of my session is that near misses are valuable learning opportunity. It provides the insight into the system weakness and without patient harm. Reporting near misses prevents future harm. Each report contributes to a safer healthcare environment. Most error are system failure, not the individual failure. So it should be improve the process rather than the blaming the individual. And more the just culture encourage the learning. It foster environment where the staff feels safe to speak up and contribute to the safety. Then nurses are critically defender of patients. So their vigilance often the last line defense against the adverse event. Every reported near misses can save the future patient. Your action make a tangible difference in the patient outcome. So as I conclude, I would like everyone to remember one message. The absence of harm doesn't mean that absence of risk. Every major adverse event was once a small warning sign. Near misses give a chance to learn before the patient suffer. So therefore, let us move from blame to learning. Let us create a workplace where the people feel safe and speak up. Because every near misses reported today may protect the patient tomorrow. Thank you everyone for listening. I'm happy to hear particular question and the discussion.
Thank you, Diksha, for insightful presentation. As for taking us in various aspects of near miss, from the definition of the near miss, what is like importance of near miss, why it should be reported, and how to create the just culture, and how to strengthen the increase the near miss, and also the highlighting the role of what is the nursing officer for reporting the near miss, plus and what is the role for nursing leader. Thank you for insightful presentation. Now forum is open for any questions and any doubts. Uh, Please post your any, questions in the chat box. Any doubts?
We have about 95 participants here. Diksha beautifully presented. I'm sure as she was presenting, you would have had thoughts of incidences which has happened for organization. So even if you share one or two, that will be a great learning to people. So please unmute yourself and share your experience of how you have identified at your workplace. We need to understand that identifying a near miss is not for punishment, it's for improvement. That concept has to be really kept in mind when we identify a situation. So making sure that the system is corrected.
We have Jyoti and Rekha Pandey has raised their hands. So please, you can unmute and talk, please.
Good evening, ma'am. Good evening, all.
Hi, good
Ma'am,
evening, Rekha.
I have one experience to share recent in within a week, and I had one question also. So, ma'am, first we had one near miss. It was about to have sentinel event. One patient was there, and as we keep telling our staff that any new admission has to be attended within 30 minutes. But since the RMO was not able to attend the patient in 30 minutes, and our nursing staff, they went and they put the cannula and they took the sample. But here at Apollo, we use IPEMR where doctors only prescribe or raise any investigation. So what happened? The investigation was not raised, so staff took the sample and they kept it in the fridge, manually written as per their statement, but I really doubt. And the second admission also came and they did the same thing. They kept the sample in fridge, which is totally not allowed to keep it in the fridge. And later, what happened that another nurse came and she sent the blood sample for blood grouping to the lab, and the same patient was posted for TKR, and she had already done with her blood grouping 5 6 days before, which was B negative, and this sample was showing A positive. So their blood bank person, they had doubt, they came again, and then again second mistake happened that blood bank person came to the floor and she asked where is the room number 533. So she recognized the patient by saying room number, and she a nurse in charge, she directed her by showing the finger ki this is the direction, and she entered in the room number 534, and again she pricked wrong patient for the sampling. So lot of errors happened, but ultimately, by third time sampling, it was recognized that patient's blood group is B negative. So it was a big near miss which was prevented because patient had already her blood grouping done 1 week before. So, ma'am, this is the scenario which could be prevented. But my question is, ma'am, after saying this thing and after percolating this message to the whole team for about 1 week, we literally conducted and all the trainings, and we ran the campaign. After that, also, day before yesterday, one nurse, she sent the sample without labeling, and she was saying, I was not aware about the process. So, ma'am, this from shifting from blaming culture to just culture, I agree. This is totally, we know, this is good for our identifying and to make our staff empowered. But sometimes, ma'am, I don't know whether it is Gen Z's problem or something, but regular training also doesn't help them.
Okay, that's a fantastic, sharing of a chain of events. Okay. So just culture does not mean that you are not going to take any action. Okay. Just culture is about trying to understand why that person or why that happened. So now there were two, three behaviors that Diksha had mentioned, right? It is available in NHS also. If you look at the NHS decision tree, there is something called a NHS decision tree where it is published in the NHS that at risk behavior, violation of process. And now I can't remember exactly, but definitely we can find it on the net. Is it's very clearly talks about what is the remedial action to be taken. Now, coming back to your story, I mean, it's a very, very interesting story. One after the other, there is breakage of safe behaviors, correct? One
Yes.
after the other. It is not just one event, multiple happening. even using the bed number, if you ask this lab person and this nurse separately, they will give you the correct answer. Correct?
Yes.
They will
Yes.
tell two identifiers are to be used whenever you identify a patient. Correct? They'll give you the right answer. So, do you think that training is the answer?
No, ma'am.
Training is not the answer, because training, we tend to say training, but if you look at the pyramid of remedial actions for any errors that may occur, training has is right at the bottom. It does not help. See, I personally feel, others can also discuss. I personally feel is that they are not serious about what they are doing, because they don't understand the effect of their error, because we tend to normalize unsafe behavior. So what happens? Every day 5:33, 5:34 is happening.
Yes.
The lab comes and say, where is 5:20? Nurse says it is there. Another floor, somebody will go and ask, where is 3:20? They say. So whoever is listening to this conversation, nobody is stopping anyone. Nobody is stopping. We are only trying to talk when the error actually happens. Though it is a near miss, but it is a big near miss. I mean, you're just
Exactly, ma'am.
sheer luck. It is sheer luck that the patient was saved
Ah,
here, right? So
yes.
number one question is that why, if I am the CNO, the question I'm going to ask first is, why was the sample kept in the fridge? The
Yes.
root cause is maybe the Armo is not available to put the order at the same time. Why is the person not available? That's the question to be answered, right? Because I
Mm.
don't know the system, so I'm just saying from whatever I heard, how will I start looking at the thing? And I think your question is more about the last one, where after doing everything. So, training, as I said, is not useful. The best thing is to use a simulation based methodology of reflection. Couple of times Diksha told, let's reflect. We are not able to reflect. Now, if you call all the people who are involved here, tell them this is what happened. I would like you to write down what all things can go wrong because this happened. Okay. We don't want to blame you. We would like you to think about what all could have gone wrong. We were lucky, but if we did not catch it, what could have happened? So they will write down everything that is required. So many years ago, when I was in Fortis, Vasant Kunj, I started a session called Learning from Mistakes. Now, today, Annie has got a book called Learning Ignited
Right.
from Errors, right? So, I used to call it Learning from Mistakes. So, anything that happens in my department, I used to call all the nurses, nurse leaders, put them in clusters, give them one paper which is kind of designed, which says incident is put on the slide, just the incident. Then I give them leading questions. Why do you think this happened? How we are going to prevent this next time? If this was not caught, what could have happened to the patient? The last question, would you like this to happen to your near one? See, it's very important to connect the heart and the brain. It
Yes.
is not that the brain does not know, they know, but it's just that we have that attitude of chalta hai. Because today I used one room number, nobody stopped me, nothing happened. So tomorrow again I will use room number. Nobody stopped me, nothing happened. So it becomes a normal behavior for all of us. We keep talking about two identifiers for audits, etc. But when we are walking around, if we even hear even a housekeeping or a GDA saying, कि मैम 301 का क्या test है? Are we stopping and saying, hello, why did you say 301? Do you know how we are supposed to identify the patient? Correct? Are we
Yes.
having those dialogues in the corridor? I mean, these are some of the reflections I would like, call the people, ask them. There is no point in training because they already know what is to be done. It is that just that. And you also had another question where you said, is it the Gen Z thing? The
anything that a process where you, when you take a sample, where the sampling has to be done, it should never be taught through a slide. You should be allowed to create a scenario. They actually take the sample, do everything. This is called the simulation. Allow them to do, allow them to do. And if you think that all the new nurses who come, they don't know how to take the samples, you should have in classroom simulation. Then also make them one day just a sample collector. Make them one day half, maybe 4 hours of sample collection. Only I used to send my nurses to OPD sample collection room because they say I have not pricked patient. So I send them to the sample collection room. And so watch, then you do at least 4 or 5 venipunctures so that you get a feeling how the vein can be filled. So we need to think a little out of box so that you can give that experience to them. See, all of us sitting here, we have a lot of experience behind us. And these young nurses who come, they don't have that experience behind them. So we have to give them the experience through any intervention. I mean, whether it is a classroom based one, whether it is a ER based one, ward based one, you know. So just asking her, was it not, taught to you during induction will not help us. Because that's
Right, ma'am.
also another problem where in induction we give 1,000 things to a new person. How much can someone absorb? I'm very sure this is hardly an hour session. Now, if we ask the people who are sitting here what all was discussed, I can guarantee that, nobody can recollect everything. Correct? It's just a 1 hour session. Then you have an induction of 5, 6, 7 days where we are going there and telling them everything. The culture, the vision, the mission, the objectives, this, that, different departments. Oh my God. I think by the time we finish, they're like, ah. So then we are wondering that what happened? We did all the training. So I think it is time for us to think now differently, disrupt the status quo. And also, it is probably also time to tell the people beforehand the consequences. I would like all of you to go and refer to the decision tree of NHS. They have a beautiful policy which says this is how, when you have some mistakes, this is how the decisions are taken, and this is how it will end. So there are situations where it is termed as negligence. What is negligence? You know what is to be done, but yet you decided not to do that. Something is by mistake, it can happen. That's a lot of chaos happening, too much of business or something we know. But someone who knows what is the right process but decides to do a shortcut will be negligent, right?
Right,
Negligent
ma'am.
has got a price to pay. So I don't know. I did one session. I think I did it in Guwahati. It was about medical legal, thing. Though I have not dealt with many medical legal thing, but I did a lot of reading and studying. Maybe I can repeat the same as a webinar for more people because there I was speaking in person. So I did a lot of homework to try just to understand what are all these behaviors about. So, Rekha, thank you so much for bringing out that. I hope you got some ideas what you can do as a CNO.
Yes, ma'am.
Yeah.
Thank you so much, ma'am. Thank you so
No
much for your
worries.
guidance.
If you want any further thing, please connect one to one, and whatever things come to my mind. See, I always think if I'm the CNO today, what will I do? And that's the answer I am giving you because I did some when I was a CNO, and today with all the kind of technology and everything available, my thought process definitely has changed over the period of time. Jyoti, your hand is up. Jyoti, CHAFB.
Hello, ma'am. Good evening.
Good
Nice to
evening.
hear you. And first of all, congratulations to Diksha. She did a fantastic job.
Yeah.
And what stayed with me was the second point were in the key takeaways. The thing is, obviously, I mean, I understand Ms. Pandey's frustration in what she has gone through recently. But the point is still that it was a system error. Everything was not in the right place, even during her problems, what she went through. So, one of the things that stayed was this, that every near miss or every fatal event, it's not necessary that only one person is to blame. There were a lot of instances which took place, incidents which took place altogether, and that is how something happened. So every incident, every near miss is an opportunity for us to strengthen our system. Like you mentioned, ma'am, why wasn't the RMO there? Maybe if it was there, then things would have moved correctly. That was one thing I wanted to tell. And second thing is about an incident long back when one of the post-op patients, injection atropine 12 milligram was mentioned. And once the nursing officer, young lady, she had just come out after training, started loading. She loaded one ampule. And when she put her hand to the other ampule, then she realized, oh, it cannot be 12. Right. And then she notified it. And fortunately, nothing much happened. But this good doctor had forgotten to either forgotten or missed, or maybe I don't know what happened to the 1.2 part of it. But I think those are the kind of things that is very, very important for us to highlight. Like you mentioned, every little incident where we could have gone wrong should be brought up in our weekly or monthly meetings that we have, and that could educate all of us. Like I totally agree with you, not everything is based on training. And the way we train, the way we bring up these fatal incidents or near miss events will be a good way of learning. Thank you so much, ma'am. Thanks, Diksha,
you.
for a good presentation. Yeah.
Thank you. Thank you, Jyoti. I think
Thank you.
very, very valid point that, it is not the person to be blamed. And the just culture is all about looking beyond the person. And that's why when we do RCA, it is important to ask the right questions, because this is where we tend to go wrong. Because even when we use five eyes, I remember maybe when I started doing this trainings in quality and quality tools, every five eyes will end with not having enough stuff. Every single mistake will end up not having enough stuff. I mean, the mind was already made that this was because of that. So slowly we had to change the way that we ask questions. Why this happened, why this happened, why this happened. If you don't ask the right question, if you ask the question you like to ask and get that answer only, then your RCA will never give you anything powerful. Correct. I think that's a great discussion, Jyoti, and it is time that we should ask, because in WHO patient safety curriculum, there is one big chapter called human factors. All the fellows, they have to do a WHO patient safety curriculum sessions. I mean, sessions means classes. They have to learn by themselves. And if you read the human factors chapter, it's very, very powerful. Because if you read that, you will have to ask the right questions. How many times do we ask that a particular nurse, let's say the nurse made a mistake? Do we ask that when did she join? When did she finish her induction? Did she do the procedure before? Has she done this procedure before? Did she perform the procedure independently? Did she get the right supervision? How many hours of duty did she do? Which shift was she? There are a lot many things. When did she get her last off, weekly off? Did she get a break? So there are many, many human factors that needs to be considered. So it's a good idea, especially to the CNOs, that you should have a set of question to ask when you're doing the RCA. To the nurse also should be party to the RCA. She should be invited so they can also give their inputs and their side of the story. It is also important. And I do agree, because I'd been a CNO. With all these things told, we do have people who are very happy doing shortcuts, right? So it is very important to highlight to them how shortcuts can one day harm a patient. That is when we start discussing about near misses, right? So, great discussion. Thank you so much, Elizabeth. You are also on the video, so you are waiting to say something, please.
Yes, ma'am. Good evening, all. First and foremost, congratulations, Dilsha. You have done a great job. Thangaraj also, he was a very good mentor for her at the same time. And I just wanted to add to what Tanga ma'am said about the personal factor. Now, that whenever we do an RCA, I always tell my quality team also, the nurse educators or the nursing quality executives, when you do an RCA, if you reach to an individual, your RCA is incomplete. Normally, everybody is ready to put the blame into an individual and just stop there. Finally, it comes to the nurses saying that she was not educated properly, so that your process is incomplete. So when you go for an RCA, if you stop it with an individual, that will not be the appropriate way. Many incidents like that. So this is what I just wanted to say, and it was an
That's a
excellent
great
session.
tip,
Yeah, ma'am?
Elizabeth. That's a great tip.
Yes,
If it ends with an individual, that means your RCA is incomplete.
exactly,
But coupling with what Jyoti told is that is usually the system failure, right?
exactly,
Something in the process, there is a hole in the process, or
exactly.
something that we overlooked, something that has been going on. So when I was a CNO, even doctors used to come and ask, Madam, छोटी सी तो बात है और आप इतनी बातें कर रहे हो, आप इतना सीरियसली क्यों ले रहे हो? तो मैंने कहा कि आप उस दिन की वेट करेंगे जब ये एक्चुअली एक पेशेंट को हार्म करे. इट इज बेटर टू टॉक टुडे, राइट? So those were the days when RCA, all these things were just coming into nursing department. Now it is pretty much prevalent, but it's all takes a lot of courage to admit that it is something that the leader has to own it and find what is the loophole in the process or in the system. Have the courage to stand up to a clinician and say, no, no nurses will do this, right? So there has to be, the leaders have to choose the battles that they want to really fight. 15 years ago, the doctors will not take the consent. But today it is with many push and pull, then doctors are taking the consent. Those were the days when I had to tell my nurses that if you touch the consent, then I'm going to take action on you. Then a doctor will shout. I said, no problem. When they shout, call me. I have to appear. So they have to pick the phone and say, Ki Tankam ma'am, please come. Doctor is asking me to take the consent. And that, even I had to run those days. I had to run 2, 3 times. Then it became a joke. The doctors will say, sister consent. Ah, रहने दो. अभी तुम phone लगाएगी मैडम को. So it is important to take the right battles. That is also, very, very important. Otherwise, theory-wise, I think we are all good. We all know the stuff, but how we do. So Diksha, from my side, I should say you, your slides were fantastic, and the last slide is quite memorable, where you had told that the near miss is a gift. It's actually
Yes,
is a gift. If we can get more of near misses and work on them, then you will spend less time on adverse events and sentinel events. Am I right? I think
exactly.
Yes.
that is what I would like to say, that, is
Mm.
more important. The good catch is a fantastic concept, but how do they feel confident that I can actually report? Within the system, you will have to be the safety soldier, because sometimes maybe your MS or somebody else is not having your attitude. They may be having a different attitude. Get a nurse and hang her, and that's the end of the story. So, as leaders, we have to stand up to that and say, no, this is not what it is. So, leaders have to be thoroughly educated with root cause analysis and other tools that we are using. So, you are able to pinpoint the process failures or the system failures that exist and what needs to be done. Correct? So thanks, Rekha. Every time you definitely come up with your own experience, and that becomes a great learning for, because
Thank you,
last session
ma'am.
also you have spoken, and that's very important. Imagine if 2, 3 more people will talk, then this discussion can go on till 9 o'clock. I'm sure of that. So thanks, Diksha
Yes.
and Elizabeth and Tangaraj did a fantastic job. Very well done, Tangaraj. The video was also great. See, more than asking for the PPTs, but every time I keep seeing that, can you share the slides? I would like you to go back and look at the recordings, what the slides can do. Go back, play the recording to your staff. It is all the safe sessions are uploaded on our YouTube channel. So you can go call your people to a classroom, staff nurses, student nurses, play that video. Then ask them to do a discussion like the way that we are doing. It's hardly 40, 45 minutes or maximum 50 minutes. Then there is discussion also recorded. So there is a whole lot of learning in that session. Give them the attendance for that session. Let it become one of your continuing nursing education intervention. It's freely available. Why not use it? Because when I look at the number of views for all the educational videos of ANEI, I know that it's not being used as effectively as it should. So at least the people who are sitting here, if you say that all my, 400 nurses, 300 nurses by turn is going to look at this particular video, or students, if you plan it. See, imagine, in one classroom, you can put all of them and play this video. So I really hope that all of you will, put a little bit more action into all the discussions that we are doing. Discussions are good, but action is very, very paramount, right? So thanks, Dr. Rusli, for holding
Yeah,
this
ma'am.
piece
Thank
together.
you.
And you can close up the session and remind them we'll see them in July.
Thank you, Diksha, for that beautiful presentation. As the important thing is, every near miss is a gift of learning, is something which each one of us have to learn. And Ms. Margaret has mentioned that scenario recreation, that is also a simulation based learning, is also a very good way of learning. So all the best to all of you who are present. As ma'am said, please go on to the YouTube and listen and play it for your educators, can play it at your sessions. Thank you. See you all next month with another
I'm
learning
sharing
session.
the YouTube link here. Those who want, you can take it from here. If you search for Association of Nurse Executives India, you will find the YouTube channel. Yeah. Okay.
Thank you so much. Thank you.
Thank you.
Thank you, ma'am.